48 hours or more than that on hypertrophic cardiac. Thank you very much, Dr. Ajay Bahl, Dr. Sudhir Saxena. Just wait for a while. Just wait for a while. Can Dr. JC give a plaque to Dr. Sudhir Saxena? He is an excellent photographer, wildlife photography, and he's traveled all across the globe to have those pics. So that is what he was talking about imaging. Just wait, Dr. Allegation. Sir, please. So I'll request Dr. Sudhir Saxena and Dr. Ajay Bahl to give a memento of appreciation to Dr. Allegation. Please. Dr. JC Mohan is coming in the background anyway. So now I go for the next talk. My job is little tough to keep the time in frame. Next speaker is Dr. JC Mohan, and I request the chairpersons, Dr. Ajay Jindal, please, and Dr. Ashutosh Bhardwaj. Dr. Ashutosh Bhardwaj is a cardiologist and a leading cardiologist of Chandigarh. His main focus is non-invasive cardiology. Dr. Rajesh Nandal is from Maulana. He was unable to make it. He's stuck in a case. But I think Dr. Ajay and Dr. Ashutosh can take the stage forward. And please introduce the speaker and please go ahead and introduce the speaker and start the talk.
I think introducing the. I think introducing Dr. J.C. Mohan itself is a very privilege for me, because whosoever is following the echo in India, I think must be knowing Dr. J.C. Mohan, because he had been a president of Indian Academy of Echocardiography, Cardiological Society of India, whatever education means education platform is there in India, whether it is Delhi Echo, Chandigarh Echo. I think he is associated with echocardiography. He's a master teacher. He has been the professor in GB Pant for like 15 years, and now presently he's the chairman of cardiovascular diseases in Jaipur Gordon Hospital. Now, I invite Dr. J.C. Mohan to deliver this talk. Thank you, Dr.
Thank you, Chairpersons. Good evening, ladies and gentlemen. The task given to me is to talk on speckle tracking imaging for assessment of LV, RV, and LA function. And I have no conflict of interest. The constituents of myocardium are cardiomyocytes, which form the bulk of the myocardium. Then there is capillaries, vasculature, about 6% of the volume, accessory matrix, which is about 25%, and there are a minuscule of conduction fibers, which don't weigh much. And eventually, of course, it is a unique structure of the cardiac muscle bundles with the intercalated discs, and of course, they behave like striated muscles. The function, heart function, depends upon the cardiac architecture, which actually means that depending upon the geometry, the mass, and the way they are laid up. Not only that, electrical activation participates in function as well as the coronary blood flow. Coronary blood flow is reduced, the function will go down. Electrical activation abnormal, function will go down. Cardiac architecture abnormal, the myocardium, the function will go down. The myocardium is elastic and incompressible three-dimensional syncytium. It is a definite architecture. Syncytial nature argues against distinct bands, definite temporal sequence of contraction, relaxation, and multiple vectors of motion. So the point which we need to remember, cardiac function, nothing but a complex process of three-dimensional myocardial deformation. And myocardium is actually, although it makes the boundary of the chambers, it is actually a non-Newtonian, almost synchronous bidirectional generator of force. That means it sucks and ejects blood actually whichever chamber we are talking about. And of course, it follows certain physics principles. We, of course, need to understand what is velocity, what is acceleration, what is force, momentum, pressure, work, and kinetic energy. But we just also have to keep in mind that force deforms muscle and propels blood. That is the whole basis of assessing cardiac function. That the myocardium generates force and this force deforms the muscle, and by deformation it will propel the blood from one chamber to another. So cavity is kinematically linked to myocardium. So whatever you see in cavity change is subsequent to myocardial force. The prime mover is myocardial force. So what we have been used to assessing cavity-based measurements like left ventricle ejection fraction, fractional shortening for a very, very long time. We have moved now for last 20 years to myocardium-based measurements, and of course we also use the combination. The function or force is a function of preload, afterload, heart rate, geometry, chamber size, and contractility. So whatever be the parameter of left ventricle function, whether it is ejection fraction, fraction shortening, MAPSA, or longitudinal strain, all will be affected by these variables, and that needs to be kept in mind. So we are not measuring intrinsic contractility of left ventricle by any of the parameters. We have been using ejection fraction for a long time. It is a unique marker of left ventricle function, has its advantages, pitfalls, and caveats, but it so happens that one size doesn't fit all. There are situations of pressure load, volume load, contractile dysfunction, ischemia, where the ejection fraction, although gives an idea, but falls short of our expectations. So as I said, in last quarter century, we have moved away from chamber analysis to myocardial analysis. We have moved from 2D to 3D, and we have moved away from manual to automatic analysis. And we are using more AI in morphofunctional image analysis, as I will show you. So let us come to acoustic speckle tracking, and what acoustic speckle tracking does is measures the strain of the myocardium. A strain is a fundamental concept in structural physiology, which means when force is applied, a viscoelastic tissue undergoes change in size, shape, and volume. So that structure is being strained actually, and you need to measure that change in size, shape, and volume, and that is what is called strain on deformation. So deformation or strain is an altered geometry with application of force, and typically in myocardium, although there are multiple vectors of strain, we look at shortening, lengthening, thickening, and of course that is how we tend to define actually strain in our clinical practice. Most commonly used strain is the longitudinal strain, where the length of a segment of myocardium changes during systole. The fractional change of this length is called actually longitudinal strain and is a dimensionless index. And hence you can see that it is denoted by a negative sign. This is because shortening is negative and lengthening is positive. We also need to keep in mind that myocardium follows Hooke's law to a great extent. Hooke's law says force developed and deformation are linked by elasticity. A myocardium has certain elasticity. If the elasticity changes because of disease, edema, inflammation, infarct, ischemia, then it will develop force to the same extent maybe, but the deformation would be less. That means strain would be less. So more elastic an object is, which means more elastic myocardium is, it will be deformed more by given force. So that is reasonable. It stands to reason that if you have a good myocardium, it will be because of force, it will be strained more, and you will get a value which is normal. But there is something else actually, and that is it is not purely elastic myocardium, it's viscoelastic. Viscosity actually offer resistance, time dependent. So what happens is strain or deformation time dependent. You apply force, the shortening does not occur immediately. It takes time. That is because of viscoelastic properties of myocardium. So Hooke's law states that myocardial force and strain are balanced by elasticity. That's the constant of elasticity. And elasticity changes as a result of architecture, fibrosis, edema, inflammation, ischemia, and multiple other things actually. So what are the vectors of deformation? And I think Dr. UP Singh did show you the vectors, longitudinal, which most commonly we use, constriction, radial or sequence, tangential, and of course, rotational ringing motion. By and large, we'll be talking today about the longitudinal strain. That is how we go. So cohesive and sequential integration of vectors of force generated ensures mechanical efficiency by optimal deformation. Why are we so much interested in acoustic speckle tracking and measurement of strain? Because we have a premise, we have a presumed premise. Premise says it provides sensitive, objective, and robust quantification of cardiac function aligned along internal coordinate system much before any other parameter provides. That is the caveat. That is the caveat. The caveat is some of the vectors of strain run ahead of displacement, ejection fraction displacement, volume displacement. So if some vectors run ahead of deformation, they would provide early information about cardiac dysfunction. How do we assess the deformation? We of course, I would be, as I have been asked to talk about acoustic speckle tracking, but we have other methods like tissue velocity imaging, velocity vector imaging, MRI and CT. And we, of course, would be talking only about acoustic speckle tracking. A speckle is a natural reflector of ultrasound. Actually, it is not an anatomical, is not a really a anatomical structure. It is that structure which actually interacts with coming sonifying beam and of course refracts and reflects it. Before I go further, Dr. UP Singh said make it interactive. So do you have audience poll? Can we do it?
We need to do it right now. I don't know whether we've done it. We can do it raise of hand right now. Raise of hand.
Okay. So I have 4 questions. I have 4 questions to all of you. So the questions are, the first question is, I regularly measure LV launch and strain my practice. Please raise your hands, those of you who do it. Good. I measure both LV and LA strain regularly. That is good. Same number, 5 number. I measure all LV, RV, and LA strain regularly. That's great. And I occasionally measure LA strain. Okay, that number is also about 25%. So 50% you don't measure any strain. Anyhow, the methodology of our left ventricle strain is simple. You need good quality apical 4-chamber, 2-chamber, and 3-chamber views, at least 3 cardiac cycles, frame rates of 50 to 80. Region of interest is from inside of endocardium to epicardium, avoid pericardium, and of course positioning of the mid myocardial layer, sequencing. You can use any sequence, but usually it is the long axis view followed by 4-chamber, 2-chamber, and starting points are just above the annulus. Now that is one point me and Dr. Manish were discussing last time. The automatic systems actually are not starting just above the annulus. They're starting right at the annulus, and sometimes they start just below the annulus. So you need to do actually the manual correction. You have to check the tracking quality, measure the peak strain, and of course you need a bullseye map for average sound strain. We wouldn't talk about radial strain, but this is how it is. So precautions while doing global longitudinal strain, I'll show you some example, but we are just talking, the precaution you need an optimal image quality, you have to study the wall motion carefully, optimal region of interest, care about annulus and apex, avoid confusing structures like pap muscle and trabeculations. So usually actually the normal left ventricle strain, global strain, forget about minus and plus is about 20%. That is the normal ballpark. And of course, plus minus up to 2%, of course, can be taken within that normal limit. Significant change if reduction is relative reduction more than 15%, and absolute reduction more than 2% is significant. And of course, time to peak strain more than 55 milliseconds, standard deviation is significant. In addition, of course, keep in mind one thing, that you need an optimal frame rate of 50 to 80. Optimal focus imaging through plane motion needs to be avoided. And of course, it is a least variable cardiac function. We, of course, with Shantanu, we did a study. Actually, we found our mean global longitudinal strain of the left ventricle minus 21%, if you talk about a single figure. But the others have suggested that regardless of clinical covariate or vendor, GLS less than 16% indicates significant myocardial dysfunction. 16 to 18% is borderline, 18% and above is normal. The longitudinal strain has a base to apex progressive gradient, and of course has an endocardial to epicardial regressive gradient. We'll show you the pictures, but the limitations of conventional acoustic speckle tracking is a lot of it operator dependent. The quality actually could be variable, and it needs intensive training. It's time consuming, and of course it has a good amount of subjective interpretation as well. So typically this is how the strain would look like. You have taken all the three views, and then of course the bullseye map comes up, and of course you get strain of all the three apical views, and finally the summed average. In this particular patient, the sum average minus 18.8. Since all are normal, they're all actually in the red color. The major limitations are methods, modality, and software version. And of course, we know that the outcome data are limited. Dr. UP Singh was referring to that. But keep in mind one thing, that we just don't measure only global longitudinal strain. We also actually look at other parameter strain like peak strain dispersion and post-systolic strain. So if you are really looking at cardiac vulnerability beyond ejection fraction, you need to get all the information which strain acoustic speckle tracking can provide you, and use it as much as possible in clinical practice. So the peak strain, I showed you the picture. The other part of the story is, of course, myocardial mechanical dispersion, which refers to the variability in the time it takes for different regions of the heart muscle to contract and relax, actually. So the shown is a two-chamber view, and you would see some of the segments are contracting. The segments are not contracting that synchronously. So this is an imbalanced biomechanical environment. Even though the global longitudinal strain may be normal, the imbalanced biochemical environment tells you this patient has a diseased myocardium and is prone to have future events. And that is an important part. So not only you measure global longitudinal strain, but we suggest that you also mention about the peak strain standard deviation always. Now that is becoming more and more important. The other thing is, of course, that most machines now have AI-enabled automatic acoustic speckle tracking, which is objective, precise, and often subtle predictive information is provided by it. But keep in mind that we are not perfect as far as the automatic acoustic speckle tracking is concerned. It still needs a little bit of human intervention. But nevertheless, in case you don't believe in human intervention, try to get as good pictures as possible. The AI-enabled automatic acoustic speckle tracking gives you expert-level diagnostic accuracy every time and everywhere. It minimizes human error, and of course, it provides you predictive insights. This is how actually the fully automatic imaging is done. Actually, once you have used a triplane, once you have used a matrix probe, and you hit the button of triplane, you get all the three planes simultaneously actually. And once you hit the button of acoustic speckle tracking, you get acoustic speckle tracking of all the three views simultaneously. And of course, you would also get simultaneously the the bullseye map as well as the peak systolic dispersion or the standard deviation. And here in it is 38, which is all right. Anything less than 55 is okay. AI-enabled strain is a big thing, and you need to spend some time on that because this is how the world is going to be in next 5, 10, 20 years. And here you train a multi-maze neural network to identify annulus, apex, endocardial curve on apical 4, 2, and 3 chamber images. Is already there in systems. Identify end-diastole and systolic frames. End systolic defined as shortest endocardial length and not the volume, and track speckles which don't go out of plane. That is what the AI-enabled strain does. So essentially, it is doing automatic view recognition, automatic contour replacement, automatic speckle tracking, and of course, you get multi-parameter results in less than 60 seconds. This enables a robust, reproducible, and one-button GLS measurement, making it an efficient tool for routine clinical use. Let me just show you an example. So we have actually on the top from a triplane image that takes about what? About 10 seconds to acquire it, maybe 5 seconds to acquire it, and you have 3 views. And then of course you press the button which says auto ejection fraction. You get auto ejection fraction at the bottom. It gives you from 4-chamber and 2-chamber view using the Simpsons method. And of course the software is EchoNet dynamic algorithm. Now you go to the right side, you say for acoustic speckle tracking, or you call automatic functional imaging. It gives you a tracking and it gives you the bullseye map and it gives you the ejection fraction along with it. That is what is the fully automatic acoustic speckle tracking. And of course, it will give you the other parameters you can also get, like the peaks, systolic, the standard deviation. And of course, you can also get actually simultaneously by feeding the cuff blood pressure, the mechanical work of the myocardium in a jiffy. That also takes less than 1 minute actually. So we have, this is actually more time saving and automatic workflow. There are, of course, distinct advantages. Gives you both volume-based and the myocardium-based. The current AI-enabled acoustic speckle tracking is giving you both ejection fraction, fractional area change for right ventricle, as well as global longitudinal strain. A little word about the peak strain dispersion or standard deviation time to peak strain, because it actually tells you is a marker of arrhythmic risk and hence needs to be measured in each and every case. And as I said, the normal value is usually less than 55 milliseconds, but some people have taken an abnormality at above 75 milliseconds. We wouldn't, but sometimes they are grossly abnormal. For example, here the strain, the standard deviation is 129 milliseconds. RV strain, you need to take an RV focus 4-chamber view and check the tracking quality, the region of interest around 5 millimeter thickness. Don't include tricuspid annulus or pericardium, as I said, an average of 3 segments of the free wall. Well, that looks fine actually. This was what we were doing mechanically. And as I said, now of course is the AI enabled automatic actually. You can take only of the free wall, you can take off the entire right ventricle, and it gives you the complete picture, including the fractional area change, TAPSE, as well as free wall strain in a jiffy. That would take probably less than 60 seconds to give you entire information about the right ventricle. And you don't have to look at it. The only thing is you have a focus RV view. And of course, you just press the button for the RV strain. It gives you all the 3 functions, fractional area change, TAPSE, as well as the free wall strain, as well as global strain in a jiffy. So the AI-enabled speckle tracking giving us multi-axial myocardial performance, muscle mechanics, and cavity kinetics simultaneously. The latest guide for quantification of cardiac cavities suggested a abnormal cutoff value for longitudinal RV free wall strain of 20%. Anything less than 20% is abnormal. This is what the 2015 guidelines are. We also can do the left atrial longitudinal strain. We know the left atrium has 3 kinds of strain: reservoir strain, conduit strain, and booster strain. One of the things you can do the same way, actually, here is the way. The other way is, of course, you have a automatic actually left atrial strain where you don't do anything. In fact, the machine does everything. All you do is just press the left atrial strain button. It will give you reservoir strain, it will give you booster strain, and it would give you the conduit strain. But nevertheless, keep in mind, in case you have a machine which is not able to give you the automatic LA strain, you need to have a LA focus view, region of wall thick, the region of interest thickness less than 3 millimeter, and of course you have to exclude the left atrial appendage and of course pulmonary veins. And the strain task force recommends tracing the left atrium to extrapolate across pulmonary veins and LA appendage. That actually the software does automatically to give you left atrial strain. And of course, you can get in two-chamber view, you can get in single-chamber view. The ASC recommends only four-chamber. The European Society recommends actually taking in both the views, four-chamber and two-chamber view. And reservoir strain less than 25%, absolutely abnormal according to the latest guidelines of the American Society Echo, and pump strain less than 8%, absolutely abnormal. Of course, if you are really looking at median value for left atrial reservoir strain is 38 and left atrial volume 24. There is a new thing which is coming for the left atrial cardiomyopathy, and that is rule of 34. If the LA left atrial volume index is more than 34, LA peak reservoir strain less than 34, that indicates presence of left atrial cardiomyopathy. Limitations of Speckle tracking are there. If you have low frame, tracking quality is bad, through blend motion, poor feasibility of segmental strain. You use smoothing algorithm to reduce noise, and of course curvature dependency and region of interest width. We have certainly moved away from traditional approach. We are using fully automatic approach. We are actually also trying to get handle on myocardial work through the myocardial strain, and those are the new things which we are doing. And even at the level of left atrium, not only we are looking at the various atrial strains, we're also looking at the atrial reservoir work and atrial stiffness index. 40 strain acoustic specking, you can also get 40 with a single actually cardiac cycle. You can get all kinds of strains: longitudinal strain, circumferential, radial strain, and of course the rotational strain. But this is less validated, is available with some of the vendors. But we did a study about 7-8 years back, and we found it correlates with 2D strain pretty well at all levels. And I would actually try to skip this, but I'm just trying to show you some of the important things which you might be of interest. Some points it gives you much more information besides the early left ventricle dysfunction. Here is a classic example of somebody who has a normal looking ejection fraction actually. But if you look at the strain is -7, it indicates severely dysfunctional left ventricle, which actually when you try to eyeball the left ventricle, you don't find it. There are pattern reading, a lot of them in amyloidosis, constrictive pericarditis, apical hypertrophic cardiomyopathy, so on and so forth, which can help you that the acoustic speckle help. This is, of course, an individual who has inverted Takasubo syndrome, where you see the strains are reduced in base and mid. And here is somebody with amyloidosis cherry on top, which was discussed by Dr. U.P. Singh. The monitoring about the cancer therapy was discussed by Dr. U.P. Singh in great detail. We would try to actually avoid that, but as I said, the peak strain dispersion, probably you should try to get it in your day-to-day practice. And adding a mechanical dispersion to ejection fraction results in superior classification of patients expecting arrhythmic events as well as patient not experiencing events. I would skip that audience poll actually, and I will just try to say by saying that strain imaging provides objectivity, quantification, new information, new physiology, more about synchrony. Large outcome data are on the way, and of course, it is a reproducible and robust method. At the end, I would like to say that the fully automatic strain surveillance of left ventricle, right ventricle, left atrium is essential part of every echo examination nowadays. And in case you haven't got to it, please go back to it. In summary, LV global longitudinal strain by speckle tracking is sensitive method to diagnose mild systolic dysfunction. When there is significant, you don't need it because it probably may not be adding much. LV segmental strain maps can provide diagnostic clues in several cardiomyopathies, but they are not routinely recommended. And LA strain is a strong marker of LV filling pressure and also has been used by the ASC 2025 in grading and identifying diastolic dysfunction and raised filling pressures. So thank you very much.
As always, it was a very nice presentation by Dr. Mohan sir. Regarding LA strain, there are few studies that show that LA strain itself can be a standalone marker for heart failure with preserved ejection fraction. So, do we have any studies from India that show the predictive value of LA strain for heart failure with preserved ejection fraction?
No, we don't have studies from India actually about the left atrial strain, but we have large amount of data which has come up from the Western world. The best study actually is from the Mayo guys, this fellow Yogesh Reddy and Barry Burlog. They showed that if you have to measure, you have to look at a single parameter of raised left atrial pressure. The best sensitivity is with left atrial reservoir strain and best specificity. Sensitivity about 56%, specificity about 94%. The other parameters fall short of that. So it is a pretty good way, but it itself probably may not be everything actually. You would have to be, combine with other parameters to get more information. We also are trying to understand the left atrial reservoir strain has a lot of dispersion, and that dispersion may help in identifying people who are going to get future atrial fibrillation or heart failure.
Sir, like in patient with the high heart failure with reduced ejection fraction, where the ejection fraction is about 25% and the septum is already scarred and mobile, it is immobile, what additional information I'll get when I'll go for the
So let us be honest, actually, the maximum information you get it when the ejection fraction is seemingly normal or nearly normal. When ejection fraction 20-25%, strain probably would add very little value. You already know that this is a patient who has bad prognosis. But the strain has certain advantages in these situations. One, of course, is individuals who have thick walls tend to have relatively normal or near normal ejection fraction, but their strain is much lower. So prognostically there, the strain becomes important. The second thing is when patients are showing reverse remodeling where the ejection fraction has normalized, the strain would provide whether you should still continue full-blown GDMT for HFrEF or you can temper with it slightly. For example, you had an individual who had 25% ejection fraction, went to 56%, you feel happy, should I discontinue or try to reduce it? But you look at the global longitudinal strain, it is still 10-11%. You know you have a long way to go. You can't afford to reduce it. So the between remission and relapse, between recovery and remission, it probably would help. Recovery is where the longitudinal strain has also normalized, ejection fraction volumes are normalized. Remission is where ejection fraction has normalized, but the strain is still lagging behind. So there are multiple ways we can look at the whole issue. But somebody who has ejection fraction, for example, HFpEF individual, ejection fraction is 60%. If you want to further risk stratify them, 2/3 of the individuals have strain which is lower and 1/3 are normal. Those who are normal, about 20%, they have a better prognosis compared to those who have reduced strain actually. So you can further risk stratify these individuals. And in a similar way about the arrhythmic risk and need for anti-arrhythmic therapy, in an individual whose ejection fraction has recovered above 35%, the standard deviation could be helpful. The data are coming up with that.
So, sir, can I have one question?
Yeah.
So, patients on chemotherapeutic agents, for how frequently then we should do LV strain in every cycle, like what are 3 weeks or 1 monthly cycle for chemotherapeutics?
There are definite guidelines by the European Society of Cardiology 2022. You can look at it. The guidelines are absolutely clear when you should be doing it. So there is a particular sequence. You have to do it at baseline. I mean, we are talking about those drugs like adriamycin, trastuzumab, and this. You have to do it baseline. Then after 2 cardiac cycles initially, and in case after 2 cardiac cycles there is abnormality, then after every cardiac cycle till it reaches that threshold where we would like to stop or reduce the drug. But at the same time, after every cardiac cycle, troponin and antipropion required. And in case troponin is abnormal, then the echo has to be repeated after every cardiac. But there is an algorithm given. You can look at it. Maybe I may be missing some part of it. I may not be telling absolutely correct. But it does tell you that ideally you should be doing after 2 chemotherapeutic cycles an echocardiogram. Maybe, Manish, do you remember anything of that algorithm? Is it after baseline and then after 2 cardiac cycles? Okay.
So
2022
it's
says
a
that,
total dose
that
dependent.
after every cardiac cycle, do troponin, anti-proBNP, and after every 2 cycles, do an echo.
Can I
And
answer, sir?
Yeah.
Yeah, I'm here. Yeah, so there are two, for trastuzumab it is different, for adriamycin it is different. So the way I remember, every echo should have a troponin and proBNP. That's for sure. It's for adriamycin, it is 0, 3, 6, 9, 12 cycle. For trastuzumab, it is alternate. But adriamycin also goes till 24 months and trastuzumab goes till 24 months also. So I think it's a good idea to see the algorithm.
But the long term up to 5 years, 5 years is mandated. Some people have suggested even beyond 5 years, but the ESC says that you should continue to do echoes after you have completed the cycle once in 6 months up to 5 years. Now that is an important issue. But the way I do is every 2 cardiac cycles. I'll do an echo every 2 cardiac cycle, and since the point of care test troponin and BNP every cardiac cycle.
Thank you, sir.
Yeah.
we can
Actually, the ESC guidelines have a color map where, according to the 5 or 6 cardiotoxic drug, say ICIs, or you have trastuzumab, etc., Herceptin. So each of them has a different recommendations. The problem is that in India we have availability of echo at our fingertips. I mean, we can actually do it as and when we require. A lot of these patients, when they go through BMT, bone marrow transplants, etc., or they have been given cyclophosphamide as a bolus loading doses, some of them will decompensate very quickly. We've had hemorrhagic myocarditis, we've had myopericarditis in these patients. So in the acute stages of if you give them 5 FU, they can actually have a coronary vasospasm, present like an acute coronary syndrome. So I think it is also dependent on how the patient presents. Some of them will go into this very strange subset of myocardial dysfunction with pericardial effusion, with it's a unique subset to cardiotoxic drugs. So I think it should be whatever guidelines are for chronic follow-up therapies, but for the acute phase, probably it will be dependent on how the patient presents.
Yeah, but surprisingly, actually, neither oncologist nor cardiology recommend any this thing. I know of centers which don't get any echo surveillance. But you are right about the drug-related. Trastuzumab causes more often pericardial effusion. 5-fluorouracil is notorious for causing a Takasubu syndrome kind of picture. Actually, so we have learned many different ways actually how. But that is one area where there is a severe echopenia, as we'll call it.
I think that's wonderful, and we